especially in atopic dermatitis. Atopic dermatitis, the therapy of atopic dermatitis is really an art. It is not just prescribing a few medications and sending the patient away. You should have a plan of action and the appropriate choice of the drug, where to use topicals, where to use systemic. Is there any need for combination? Is there any, going beyond what you are prescribing? All these are very important in the management of atopic dermatitis. So we now have two very important speakers, both from Kolkata. One is Dr. Raghubir Banerjee, and he will be talking on the topical therapy of atopic dermatitis. Raghubir, I don't know whether Raghubir is known to the South Indian students. Raghubir is a very good pediatric dermatologist, and he in fact shaped the pediatric dermatology practice in India, and he is very active among the pediatric forums. So I ask Dr. Raghubir to go ahead with the presentation. Over to you, Raghubir.
Am I audible?
Yeah.
Thank you, sir, for the kind words. Dr. Crichton has been our teacher, one of the mentors in pediatric dermatology for me and Rajib. And he is an inspiring figure as far as pediatric dermatology goes, because when we started pediatric dermatology in ISPD, Dr. Crichton was there, and he was the source of inspiration for pediatric dermatology for us young people at that time. So thank you, Dr. Crichton, for inviting us for this lecture. Well, going into the topic, as sir has already mentioned, that atopic dermatitis, the treatment of atopic dermatitis is an art. You cannot go fully by guidelines, fully by algorithms. So the treatment is definitely an art, and you have to devise your own modality of treatment according to your own clinical experience. As you know, this disease is very chronic and relapsing, and sometimes very frustrating for the patient and the clinician alike, with a lot of relapses, lot of waxing and waning. So there are numerous difficulties when you treat this disease, especially the flares. Now, in atopic dermatitis, what we need to address is definitely the skin dryness, the itchy sensation that the patient gets, the extreme pruritus, and of course, topical therapies to suppress the inflammation. Now, going a bit into the history of atopic dermatitis, it starts long back in 1870s, where Raghubir has advocated treatment with oil, lotions, ointments. Then the treatment has evolved over years. In 30s, we had emollients and moisturizers. In 1960s, the topical corticosteroids came into the picture. In 2000s, we had the steroid-sparing agents like the calcineurin inhibitors. In 2017, we have newer molecules like the phosphodiesterase inhibitors, the JAK inhibitors, and so on. So the treatment is slowly evolving with time. But certain old things like emollients, oils, they are still very necessary for general skin care of atopic dermatitis patient. Now, what will be the treatment approach in case of atopic dermatitis? We have the first line agents, of course, is still the moisturizer, the emolliation to prevent the xerosis, dryness of the skin, to reduce the itching inflammation. Then we have topical anti-inflammatory agents, topical steroids, immunomodulators, and so on. So the skin-directed therapies are very, very necessary for treating atopic dermatitis patients. And of course, though we have a lot of new molecules coming in, but general skin care, like bathing practices, like emoliation, they form the cornerstone of therapy when you're treating a child with atopic dermatitis. So this is just a step ladder pattern, how you will escalate the therapy or go on. Starting from baseline, a very important thing that I have realized in my practice is that educational programs, education of the patient, the parents is very, very important. You have to set realistic goals, explain what is the disease process, how we are trying to manage it, how we are trying to prevent relapse. And these things need to be talked out at the very outset. If you do not do this, you will not get compliance of the patient. The patient will drop out and the compliance will not be there. So an educational program, a counseling, or what we call a TPE or a therapeutic patient education is very, very important as a baseline therapy. Then, of course, avoidance of the trigger factors is important. For mild disease, basic therapy, then topical anti-inflammatories like corticosteroids are good enough. For moderate therapy, for moderately active disease, we think about proactive therapy that I will talk later on to prevent the flares or relapses. And for severe disease, my colleague and brother, Dr. Rajib Malakar, will take over, where we need systemic interventions to control the disease. Now, I have divided my talk into a few parts. Like first, I'll talk something about the general skin care, which I consider very important in dealing with this atopic dermatitis patients. Then I'll talk about the topical corticosteroids, the topical calcineurin inhibitors, and then I'll go to the newer topical agents that is there. Now, as far as general skin care goes, as I've already mentioned, this is a very important aspect. This will help to maintain the skin barrier of the patient of atopic dermatitis, which is very, very vital in long-term treatment of such patients. Now, topical management with general skin care, I consider it very important that you explain this few aspects, though they may not seem very important, like bathing practices, especially in the hot, humid conditions that we are experiencing in our part of the country now. Bathing, cold water sponging is very, very important. Even in these hot, humid conditions, we get extreme pruritus for these patients. So not only dry skin, this heat and humidity may aggravate the condition. So what softer bathing practices are very important? What should be the temperature of the water? How long to give the baths for the baby, and so on. Another important aspect is wearing of loose cotton clothes, especially in the hot, humid condition. What soap to use? Especially, we prefer the Syndet or the liquid Syndet soap, not having much of fragrance or preservatives, so that you do not irritate or cause any contact dermatitis. Dr. Hannison, at the very outset, long back, had suggested a 15 to 20 minutes minimum of bath. That is something we mention nowadays as soak. Soak is having the bath, and then you go in for application of emollients like moisturizers or topical steroids. So this is very important to have a soak and seal method. Soaking, that is the bathing practice. Sealing is with the moisturizer, emollient, and of course, the topical steroids or calcineurin inhibitors as and when necessary. Well, we have something like the bleach baths. It's supposed to work very well. I personally have not much experience or do not advocate for our patients in this part of the country, but bleach baths do work well. They can be given about twice a week for the patients. And here you can see how to make a bleach bath. Not only these bleach baths have anti-staph action, but they have more of anti-inflammatory effect. So they are important as anti-inflammatory agents. About oils, many people they ask about what oil to use for these patients. We prefer sunflower oil, we prefer virgin coconut oil, because these oils have a lot of linoleic acid, which acts as a good emollient and as an anti-inflammatory agent. Try to avoid a bit of olive oil and things. Though olive oil is more expensive, olive oil and mustard oil can be irritant for the child's skin. And of course, moisturizers, we always prefer whites of paraffin, the light liquid paraffins, and the more expensive ceramide-based moisturizers are also there. So moisturization is very important. Immediately after the bath, moisturize the whole body and apply corticosteroids on the hot spots or on the affected areas. Some advocate application of the steroid before the moisturization to the specific areas, then moisturizers. Some school of thought, they say first moisturizers and then the topical steroids. Either way, it works. And very, very important is when you look at a therapeutic moisturizer nowadays, you will see 10, 15 ingredients. So this is where the problem starts. You have aloe vera, you have this, bisabolol, niacinamide, and so on. So you should be very careful about what is the vehicle. Does the vehicle have a lot of propylene glycol, formaldehydes? Because this can be a source of contact dermatitis down the line for the atopic children. So try to use bland moisturizers. The lesser the ingredients, the better. That is my viewpoint. Because even with now upcoming brands, a lot of the brands I've seen, they have a lot of 15 to 20 ingredients. So that is not something that I am happy about. So the lesser the ingredients, the lesser chance of contact dermatitis in the child. So use a bland moisturizer. And of course, colloidal oatmeal baths and all are very good. And this is how the general skin care should be advised to the parents or to the patients. The bathing practice and the moisturization are two very important things. And of course, if you're using oil, what oil to use and how to use. So the general skin care forms the cornerstone of therapy, and you'll be surprised to know what is advocated, how much emollient per week the child should be using. So for atopic dermatitis, minimum 150 to 200 grams should be used in the child per week. Then you know that sufficient amount of moisturization is being used by the child. This is one thing I wanted to mention, and we do in our practice once in a while, is the application technique. And I already mentioned whether it's the moisturizer first or the topical steroid first. There is an application technique specially for recalcitrant disease, for moderately severe disease. This wet wrap works very well. It's easier to do. You apply the wet wrap with either the moisturization or the diluted topical steroid. First should be the wet layer and then the dry layer, and keep it for an hour or so every day. So this increases the penetration 4 to 5 times. So wet wrapping is a useful technique. Sometimes overnight in our hot humid condition, you can ask the child to wear wet pajamas and all, so that there is a bit of soaking, and on top of that, you can use the moisturization. So first is the wet layer, soaked with the emollient or the steroid, and then should be the dry layer. This can be done over a period of 2 to 3 weeks to increase the penetration of the drug and to bring the disease under control. And of course, when a layer is applied, the child cannot itch and scratch as easily. So wet wrap is easier to advocate, and there's a lot of good amount of patient compliance if you explain the procedure carefully to the patient. And initially, this helps to bring the disease under control very well, especially for recalcitrant or lichenified patches, which are not being so easily brought down by topical application of the ointment. Now, coming to the topical corticosteroids, these molecules, you will be surprised to know, as I was preparing for the lecture, I found out that over 100 RCTs are there for topical corticosteroids in atopic dermatitis in children. So they still are the first line drug for treatment topical treatment of atopic dermatitis, mild to moderate, and even as adjuvant for severe disease. When you are using systemic medication, you still continue with topical corticosteroids. So topical corticosteroid is still a very important molecule. And as I've already said that they can be used, but a lot of changes have gone regarding their usage. We are not advocating long-term use. I'll come to that later on. Now, just to refresh your memory, since this is a PG lecture, so this is an easy classification for you to remember. I remember it like this, is there are the 7 classes, with class 1 being the strongest, the clobetasol, and the class 7 is the hydrocortisone group. We deal with around 4 and 5. That for atopic dermatitis in children, I'd like to use a fluticasone or a mometasone in cream base, because these work very well. These are the mild to moderately potent corticosteroids, and if used properly, they are very good as first-line therapy for atopic dermatitis. Now, some important tips that you have to remember when you're dealing with topical steroid in the pediatric age group. As you all know, that children have an increased body surface area to weight ratio. So the chance of systemic absorption is high, especially over the body folds and nappy area. You should be careful and apply a relatively thin film. Avoid prolonged use, not beyond 3 to 4 weeks. So especially for these folds, go in for a lower potent steroids. For the other areas, you can use a higher potent steroids. And of course, intermittent therapy, leave a gap. Intermittent therapy is advisable when you are using the steroids. Now, how much to apply? Often we see in our patients, like we apply butter on toast or bread, they think that if they apply more on the skin, it works faster. So again, the part of counseling comes where we have to explain how much to apply. Take a small amount, use a very, very thin film or thin smear on the affected area. Do not go in for vigorous rubbing. So these are things that have to be explained. If you apply more, it will work fast. That is not the case. Often we use twice daily applications, but we have a lot of papers advocating once daily application works as well as a BD application for these patients. Again, to refresh your memory, you all know about the FTU or the fingertip unit. This is how we gauge the amount to be applied, but in practical aspect, we cannot explain this to the patient. You have to devise your own method of how to apply. So they should apply a very thin film and not too much, unnecessarily wasting the drug. Well, these are some other tips that I'd like to mention when we deal with topical corticosteroids. Twice daily application, small amount, thin film. Try to avoid combinations, because often we see patients coming from general practitioners or other practitioners applying combinations, triples, combination with antifungals. So try to dissuade from combination. Use the lowest potent steroids that you think will be effective for the present condition. You can switch to a higher or more potent molecule if you feel that there is too much of lichenification or the pruritus is intense, or to increase the compliance. But that should be for a very short time, not beyond 2 weeks. And then you switch to a lower potent steroid to maintain. These are some clinical photographs of patients from our Institute of Child Health, where myself, Professor Sandipandhar, and Rajib, we are working together, especially for lesions near the eyelids. Here you have to go in for a low potent steroid like a hydrocortisone or a desonide, that is class 6 or 7. Otherwise, there's a risk of intraocular tension going up. If you have localized lesions like this in the child is very irritable, the lesion is very itchy, I'd prefer something like a fluticasone over the area, and within 2 weeks, you can see the patient has responded very well. So according to the site, you have to adjust the molecule that you are using. What molecule? Any problem? Yeah. Well,
No, somebody.
somebody is audible anyway. But there are certain combinations where we use topical antibacterials. Mostly topical antibacterials we do not use routinely. If there is a secondary infection in atopic dermatitis, we prefer a systemic antibiotic therapy and not a topical one, because with topical long-term use, there is a chance of resistance or contact dermatitis. But there are certain indications where a steroid antibiotic combination may work over a short period of time. So these are the situations where we use a combination for a short period of time. For localized disease, a localized patch of atopic dermatitis, especially these retroauricular or these smaller lesions, these are the areas where a topical fluticasone plus maybe a fusidic acid combination for 2 weeks works well. So otherwise, we do not advocate use of topical antibacterials for routine treatment of atopic dermatitis patients. This is one question that may cross your mind: steroid resistant AD. Is there at all something called a steroid resistant atopic dermatitis? I don't think so. You have to delve deeper into the cause. Why is the patient not responding? In that case, think about non-compliance, think about undertreatment, think about steroid phobia, or maybe the potency of the steroid you have selected is not right. So a lot of issues are there for treatment failures. So instead of stamping it as steroid resistant AD, we should go into the causes of non-compliance or causes of the patient not responding. When coming to overuse of the steroid, sometimes the patient don't come to you, they feel that the molecule has helped them, they go on applying. So this is where the problem starts in our country, where they buy the medicine over the counter and keep on using it. Sometimes you get this sort of stry or stretch marks. On the face, you see there's significant amount of erythema and early telangiectasia developing in the child. This is reversible, but this may occur with overuse of steroids on the face. Well, some amount of hyperpigmentation is very common. And of course, perioral dermatitis, this child had used a fluorinated topical steroid for 6 to 8 weeks on the face and comes with this perioral dermatitis. So these are the certain things that you have to keep in mind when using topical corticosteroid in these children. This case, myself and Rajib, we had seen in our OPD about a month back. This child of atopic dermatitis was given a potent steroid by some outside practitioner, non-dermatologist, of course, clobetasol or something. And the child was going on applying this. And this is, you can see for yourself, the Cushingoid features have come about. So even today, we can see children with these complications, with overuse of potent topical steroids, with systemic absorption, HPX suppression, and developing iatrogenic Cushing's. You can see still the erythema on the face, a little bit of ulceration has occurred in this child. Now, steroid phobia. This is something which I was talking about, and we need to deal with it in day-to-day practice, especially with Google around. The people will search for it. Sir, you have given a corticosteroid. Steroid is not safe. So that is a time we have to address this corticophobia or the steroid phobia. Again, the role of counseling comes. You have to tell them that this is not going to get absorbed. We are using it for a short time. This is a good molecule. There's nothing to worry. And of course, internationally studies have been done, and the Topicop score has been, it's a questionnaire-based score which has been devised to assess the steroid phobia internationally. So steroid phobia is not a problem in our country alone. Steroid phobia is an international problem. So this is something we need to address. when we are prescribing topical corticosteroid for atopic dermatitis. Now, shifting to the next molecule is the calcineurin inhibitors. Of course, Tacrolimus in AD, you all know we can use it above 2 to 15 years. Both strengths are available, though for children, 0.03% is advocated. But we have seen in our practice that 0.03 doesn't work that well, and we are happy with 0.1, even for children. Of course, twice daily application can be done, and we can continue for 4 to 6 weeks and then switch over to maintenance therapy. They are more safe and very effective on the face and flexures where we are not happy with topical steroids. This is the point where we can switch to the topical calcineurin inhibitors. Of course, do not use them under occlusion. They are not to be used under 2 years of age, and sun exposure may irritate the skin. Well, they are not recommended for Netherton syndrome. So this is something which I want to make a comment, that topical pimecrolimus has been used in Netherton syndrome where it has not involved more than 50% of the body surface area. It has been found there is not much of systemic absorption, and pimecrolimus has worked very well even in Netherton syndrome, though technically we are not supposed to use it for that. And of course, over oral mucosa, it's not advocated. You all know about the initial burning sensation we can get with tacrolimus. If you can counsel the patient that initially for 2 to 3 days, the burning sensation is there, it is good enough. I have found good compliance with that. Or some people advocate that you have to cool the tube in a refrigerator maybe 15 to 20 minutes before application to reduce the burning and the stinging sensation. What are the advantages of tacrolimus? There is no skin atrophy, no tachyphylaxis, there is minimal systemic absorption. They can be used long-term over 12 months to 1 year. So these are the certain advantages that the topical calcineurin inhibitors as a whole have over topical corticosteroid. This is the initial article that was done from the Institute of Child Health, Professor Sandeepan Dhar. That time it was not available. Some NRI patients had got these molecules from Fujisawa, Japan. It was very expensive that time. We had done it for about 15 children. We had used the 0.1% and got very good results for these children with atopic dermatitis. Pimecrolimus, of course, is my preference for when I'm treating atopic dermatitis for the face, the perioral lesions, or the flexures. It's a good molecule. It has less irritant potential than a tacrolimus. So when you're evaluating vis-a-vis topical steroid, topical tacrolimus is almost as effective as a mid-potent to higher potent topical corticosteroid. Pimecrolimus is as effective as a mild topical steroid without the side effects of the topical steroids. So here we can see which are the body surface area, which are the molecules which are preferred. As I've already mentioned, for face flexures, I'd prefer a TCI, and for the other areas like palm soles, a mid-potent topical steroid. Of course, trisoberol is the next molecule. So here in this slide, even when the skin is flare,
You are not audible, Raghubir.
Sir, please unmute, sir. Hey. Sir? Sir, please unmute, sir.
yeah. Can you hear me now?
Yes, sir.
Okay. Correct. So even when the eczema is looking that it's under control, underneath the barrier defect remains on the hotspot. And these are the areas we have to address to prevent the flares. So here comes the role of proactive treatment. So even when the eczema is under control, with mid-potent TCI, we can go in for twice-a-week application over the areas where we see the disease is relapsing on those sites, either with a TCI like a Tacrolimus or with a mid-potent topical corticosteroids. So this is the proactive approach. It has been there for quite some time from 2013. And to reduce the long-term flares, this is what we do. Now coming to the, since time is short, I'll be rushing a bit. What is the newer molecule? As you all know about Crisaborol, it is available. It's an expensive molecule. It is a PDE4 inhibitors, supposed to work very well. It has been given over 3 months of age, even for the face and flexures, supposed to work well. I do not have any much of personal experience with the molecule. Then we have the Roflumilast, which is coming into the market. Ruxolitinib is already there in the international market. So these are the certain newer molecules, the topical JAK inhibitors, topical PDE4 inhibitors, which are the newer molecules coming into the market for treatment of atopic dermatitis. And of course, this molecule is showing promising results, the tapinarof, which is an aryl hydrocarbon receptor modulator. So these are for, personally, I do not have much of experience regarding the molecule, except a few patients have used Crisaborol, but the cost is very high. So cannot give for all patients, especially in our resource poor setting. And of course, one interesting thing about Crisaborol is it has a very, very fast onset of action as early as from the second day compared to vehicle. So the molecule is fast acting. This molecule has lesser amount of topical irritation and is useful for mild to moderate atopic dermatitis as a topical therapy. Now, these are the 2023 JAD guidelines published in January in the Blue Journal. And you can see here the different modalities of treatment, the strength of recommendation, and the level of evidence. Why I am showing this is to impress the fact that use of moisturizers is very important with the strength of recommendation A, bathing practices, and one more thing I've highlighted, as I've already mentioned, the proactive use of TCI for maintenance. Twice weekly or an interval therapy of using the topical steroid or a TCI to prevent the flare or prevent the relapse. Of course, as we had mentioned at the very outlet, the psychological and the educational intervention for treatment of atopic eczema is very, very important to maintain the patient's compliance and adherence to therapy. I hope that the PGTs do have some take-home messages from the lecture. And this is something that my colleague, Dr. Rajib Malakar, will be taking up, stepping up treatment from moderate to severe AD. I'll not go into the details with this. This is something which I found very interesting. The Society for Eczema Studies had its first conference in Kolkata last year, and they had made an wall for atopic dermatitis, where the history of atopic dermatitis was depicted in this wall. So when we are talking of atopic dermatitis, before reading audio, I thought that showing the wall will be of interest to you. Thank you very much. Thank you, Dr. Crichton, for giving me the opportunity for the lecture. Thank you, sir.
And thank you, Dr. Raghubir. It is very, very interesting. And as you rightly pointed out, it will be very useful for the postgraduates since they are going to practice shortly. There are a lot of practical tips for them to depend on. So congratulations, Dr. Raghubir. I think now, without much wasting time, we can go ahead with the presentation of Rajib. Rajib is ready?
Sir,
Yeah.
so I'm here. He needs to unshare his screen.
Yeah. Dr. Rajib Malakar, that is his full name. He is from Kolkata, from the very same place as Raghubir. And we all work together in various capacities in ISPD. Now, Rajib has grown up to a very important person in pediatric dermatology. He has a lot of experience, and he will share his experience as well as his understanding of treating atopic dermatitis with systemic medication. And again, I reiterate, the treatment is an art of atopic dermatitis. So you should not completely depend on atopic dermatitis, or rather, you should not stay with atopic dermatitis. And when time occurs or when there is a necessity, you have to shift to systemic therapy, or even a topical plus systemic as a combination. That can also be done. So over to Rajib.
Am I visible and audible, sir?
Yes.
Sir, thank you for such a nice introduction on the subject and ourselves. Sir, you have been one of our inspirations for pediatric dermatology because of your unique, pragmatic perspective on the disease. Now, good afternoon to all of you. I'd like to welcome you today to today's presentation on overview of systemic therapies of atopic dermatitis. To the left side of the screen, the photograph is of Institute of Child Health in Kolkata, where I work in the pediatric dermatology department with Dr. Sandipandhar and Dr. Raghubir Banerjee. They are my teachers, mentors, and guides. Atopic dermatitis is a chronic inflammatory skin condition that significantly impacts the quality of life of patients. Let's start by providing an overview of the current management strategies for atopic dermatitis, acknowledging that while topical treatment and phototherapies are effective for mild cases, they may not always be sufficient for patients with moderate to severe atopic dermatitis. This is where the systemic therapies come into play, offering a more comprehensive approach to disease management. To enumerate the most commonly used systemic therapeutic options, we have the classic systemic steroid, followed by the immunomodulator / immunosuppressive cyclosporin, the pure immunosuppressives like azathioprine, methotrexate, mycophenolate mofetil, and the new kid, so-called quote-unquote, the magic molecule dupilumab, and some of the honorable mentions like apremilast, omalizumab, and ustekinumab. Having presented this list, let us now delve into a little bit details of each. In my presentation, I have incorporated the current consensus on important clinical questions regarding the use of these agents pertinent to atopic dermatitis. The source is written beneath as a footer. So moving on to the first molecule in the group is systemic steroid, such as prednisolone and methylprednisolone has been in use in the short-term management of severe atopic dermatitis flare-ups. They provide the rapid relief of symptoms and can be effective in controlling acute exacerbations. However, the long-term use of systemic steroids is generally not recommended due to their potential for significant side effects, including immunosuppression, osteoporosis, and metabolic disturbances. So their uses should be limited to short courses and under close supervision, sort of a bridge for other slow-acting systemic therapies, which can be used for longer duration. Now, let us see what the consensus we have about the use of these systemic steroids. Again, as I have mentioned, the first question that has been put for consensus was the short-term treatment of oral glucocorticoids are used to interrupt acute flare of ADB, may be considered, especially in adult patients, but in exceptional cases also in children, and should be combined with the concept of subsequent treatment modalities of their discontinuation, the so-called bridging between the two forms of treatment. And we have a very strong consensus on this way of using this molecule in atopic dermatitis. The second one is, of course, as has been mentioned, because of the adverse effect, the long-term treatment of atopic dermatitis with systemic glucocorticoid is not recommended. We have a strong consensus here too. With this, let us move on to another very important and very commonly used molecule, cyclosporine. This is a immunomodulatory / immunosuppressive, which has been extensively studied for treatment of severe atopic dermatitis. It works by inhibiting T-cell activation and reducing inflammatory responses. Clinical trials have shown that cyclosporine effectively improves symptoms and quality of life in patients with severe atopic dermatitis. However, its use is also limited by potential nephrotoxicity and hypertension. And there is a need for regular monitoring of blood pressure and renal function. Therefore, cyclosporine is typically, again, like systemic steroid, is reserved, but for short to medium duration use in acute and severe cases of atopic dermatitis. Let us now look at what the current consensus is on its use in atopic dermatitis. The first question that has been put is, when used cyclosporine for atopic dermatitis, individuals' expected risk-benefit ratio assessment has to be done in comparison to possible therapeutic alternatives. And there is a strong consensus for that. The number two, the initial dosing has to be between 2.5 to 5 milligram per kg. The same dosing that has been used for psoriasis in 2 single doses. We have a strong consensus here also. Next, how to use and continue using. The induction treatment is recommended with 2.5 to 5 milligram, should be maintained until a marked improvement has been achieved, and subsequently to be reduced in a stepwise fashion at the dose of 0.5 to 1 milligram per kg per day every 2 weeks. And this is to be continued till an individual maintenance dose has been reached. We have a strong consensus here also. Next, before initiation of the treatment, patient must be examined, especially with regular regard to blood pressure and renal functions. We have a strong consensus here. How long to use? If the response is good, interruption after 4 to 6 months is recommended. We have a strong consensus here. Now, certain important things that need to be kept in mind. Due to increased risk of skin cancer, cyclosporine treatment of atopic dermatitis should not be combined with phototherapy. An important thing to remember here is that these data are largely for Caucasians. How much it is truly applicable in skin of color or Indian skin is yet to be elucidated. We have a consensus here, which is not strong. And optimal UV protection is recommended during cyclosporine therapy, again, which is a derivative of the previous statement. We have a strong consensus here. These are to be taken with a bit of salt. Whether it is truly applicable in our case, that needs to be studied further. Moving on to the next molecule, we are going into the truly immunosuppressive realm here. This has been used in treatment of atopic dermatitis. It works by suppressing T-cell proliferation and modulating the immune response. Clinical studies have demonstrated its efficacy in reducing disease severity and improving symptoms in patients with atopic dermatitis. But its use is associated with potential side effects such as myelosuppression, hepatotoxicity, and increased risk of infection. Mind you, this is a true immunosuppressive with a significant myelosuppressive potential. So close monitoring of blood counts and liver function is necessary during treatment with azathioprine. So how and if we use it, how to use it at all? So again, azathioprine, if you use it, remember this is used as an off-label indication for treating chronic severe atopic dermatitis. Generally, if dupilumab or cyclosporine are ineffective or contraindicated, we have a majority consensus here. Again, the total experience of using azathioprine nowadays is not very large. So many of the people, many of the experts do not agree to using this molecule in case of atopic dermatitis. But there will be certain niche where you can use it, especially if there is contraindication to using other medication. Next, it is more of a caveat for using azathioprine where you need to assess thiopurine methyltransferase before starting medication so as to reduce risk of bone marrow toxicity. We have a consensus here. And again, as of cyclosporine, phototherapy during azathioprine treatment is not recommended because of the potential increase in carcinogenesis. And optimal UV protection is recommended during azathioprine, following the same logic or rationale. Let us now move to a new molecule, methotrexate. It is another immunosuppressive, which is an anti-metabolite and has been used in the management of severe atopic dermatitis. It inhibits DNA synthesis and cell proliferation and thus reduces inflammation. Clinical trials have shown that methotrexate can effectively improve symptoms and quality of life in patients with atopic dermatitis. However, it carries the risk of hepatotoxicity, bone marrow suppression, and teratogenicity, which necessitates regular monitoring of liver function and blood counts. But a very important advantage of this molecule is that it can possibly be considered for long-term use in chronic severe atopic dermatitis to maintain remission, which has been achieved by cyclosporine or other short-acting medication or fast-acting medication, which cannot be continued for a longer duration. So the clinical question here, which has been put forward for consensus to the expert, was that use of methotrexate, again, till date off-label, can be considered for long-term treatment of chronic and severe atopic dermatitis, and we do have a strong consensus here. This is followed by another immunosuppressive medication. There is also a unique niche of using this molecule, the mycophenolate mofetil. This is again an immunosuppressive agent and has shown promise in the treatment of atopic dermatitis. It inhibits lymphocyte proliferation and reduces inflammatory response. Limited data from case reports and small studies suggest mycophenolate mofetil may be effective in improving symptoms. And this is very important, it can reduce the need for topical corticosteroids in atopic dermatitis patients. So there is a potential of using it as a form of a maintenance therapy along with topical therapy. However, more research is needed as we have very small amount of data to approve its extensive use in atopic dermatitis. The clinical question here that is being asked is, as the last point suggested, mycophenolate mofetil may be considered in individual off-label, again, cases for treating chronic and severe atopic dermatitis, especially for maintenance therapy. So this is another molecule which can be used for a long-term duration. In particular cases, we have a consensus here, if not strong. And obviously, this is not again related to the treatment per se in atopic dermatitis. This is used in reproductive age group females. Moving on to the next molecule, or a very important molecule, which is in now in focus, which is dupilumab. So dupilumab is a monoclonal antibody which is targeting interleukin-4 receptor alpha subunit and has revolutionized the
No.
treatment of moderate to severe atopic dermatitis.
Ah,
Clinical trials have consistently shown its efficacy in improving symptoms and reducing disease severity and enhancing quality of life. In a pivotal phase 3 trial, significant improvements in pruritus eczema severity and quality of life were observed in patients treated with dupilumab compared to placebo. The main advantage of dupilumab is that it do have a favorable safety profile, with the most common adverse effect being injection site reactions, conjunctivitis. It has been approved by regulatory authorities in many countries for treatment of moderate to severe atopic dermatitis. The consensus statements we have here, number one, dupilumab can it be recommended for treatment of chronic moderate to severe atopic dermatitis in adolescent aged 12 years and older and in adults who cannot be adequately treated with topical medication alone? We have a strong consensus here. Number two, in case of children below 12 years of age, can it be considered for treatment in treatment refractory severe atopic dermatitis? This has been a treatment option. Now we have expert recommendation on dosage in children up to 6 months of age. This was off level at 2021, but now it has become on level. We have a consensus here. And lastly, in case of evident eczema, a combination of dupilumab with topical anti-inflammatory medication can be used. We have a strong consensus. So again, here is a case where we can combine systemic and topical therapy for long-term and faster remission in atopic dermatitis. These are the main molecules that we use nowadays for severe and atopic dermatitis. Mind you, these form of treatment that I have been talking about is used only in a very small percent of people with atopic dermatitis, because majority of the children with atopic dermatitis or adults with atopic dermatitis tend to present with mild to moderate disease. The severe disease is comparatively rare. So you need to consider this systemic management only and only if it is truly needed and other forms of therapeutic intervention has proven to be unsuccessful. As Dr. Raghubir Banerjee has shown, I will also show a therapeutic step ladder which clearly demonstrates the specific niche where this treatment is to be considered and instituted. So before moving on to that algorithm, I would like to describe some honorable mentions. As I enumerated before, number one, in the consensus statement, it was asked whether the treatment of atopic dermatitis, apremilast is recommended. It is not till date. So there is a strong consensus that treatment of atopic dermatitis with apremilast is not recommended, in spite of this molecule showing promise in the treatment of atopic dermatitis, number of case reports which suggest it has got positive outcome in patients of atopic dermatitis. Till date, there is no recommendation to that direction. Number two, omalizumab may be recommended for chronic urticaria, but as of yet, in the treatment of atopic dermatitis, it is not recommended. And lastly, ustekinumab, which is a biologic which is used in psoriasis. The recommendation is not there for treatment of atopic dermatitis as the sole indication, but if it is associated with, or if there is additional diagnosis of psoriasis, which you will commonly encounter since both of these conditions are extremely common in our population, like psoriasis, psoriatic arthritis, rheumatoid arthritis, or chronic inflammatory bowel disease are present as well. The treatment option to add ustekinumab may be considered, and there is a strong consensus in that also. So this is the treatment algorithm that I have been talking about, and this is what has already been shown by Dr. Raghubir Banerjee. So we start in a very mild case, when the patient primarily presents with atopic dermatitis, that is dry skin, one of the minor manifestations, we use moisturizers and avoidance of triggers. So avoidance of triggers and proper skin care are the two most important basic pillars of treatment, which we need to start from the very beginning and continue till the end. The next phase is when patient presents with mild eczema. Here, along with these two steps that I mentioned in the first stage of the condition, we can use low potent topical glucocorticosteroid with or without topical calcineurin inhibitors. If there is moderate eczema, along with all the previously mentioned intervention, we can use higher potent topical glucocorticosteroids and or topical calcineurin inhibitors. And only in the last step, where there is persistent severe eczema that cannot be treated adequately with topical therapy alone, we need to use or consider systemic therapies as discussed so far. But you need to understand, just by using systemic therapy alone, we may not be able to obtain appropriate response, and the necessity to using systemic therapy in a much higher dose remains. So in conjunction with the systemic therapy, the other steps need to be followed. And as clinical remission is achieved, the long-term goal should be to gradually taper off systemic therapy and continue with the topical therapy, which again needs to be reduced gradually in favor of skin care and avoidance of triggers. That is how a remission stage is maintained. So, in conclusion, what I might say is that systemic therapy plays a crucial role in the management of moderate to severe atopic dermatitis. While systemic steroids can provide short-term relief during flares, their long-term use is limited due to potential side effects. Cyclosporine is an immunomodulator. Azathioprine, methotrexate, mycophenolate are immunosuppressive right away that have shown efficacy improving symptoms, but however require careful monitoring for potential adverse effects. Dupilumab is a biological agent targeting the interleukin-4 receptor, has emerged as a highly effective and well-tolerated treatment option for moderate to severe atopic dermatitis. Apremilast has shown some promise, but yet to be established. It is essential for us to consider individual patient characteristics, disease severity, and treatment goals when selecting a systemic therapy for atopic dermatitis. Regular monitoring and close collaboration between dermatologists and patients are crucial for optimizing treatment outcomes and ensuring patient safety. I hope, in a nutshell, that covers the basic aspects of systemic therapy that we normally use in our day-to-day practice. With this, I thank you for your kind attention, and I thank again Dr. Sebastian Crichton and East West Pharma for having me here. Thank you all.
Thank you, Dr. Rajib Malakar. It's a very nice presentation, and you gave, in fact, an overview of systemic treatment, the drug options, and where to use, and how to use, how long it should be. All this are elucidated very well. Of course, we need a lot of discussion over this area, but this is not the format for discussion. I urge the postgraduate students to go details of what they have already told and take the essence out of their talk and try to practice what they have told. And Rajib has given a very beautiful reference, and it is better you go to the reference and read once again, so the lecture will be better understood. So thank you, Dr. Rajib, for your good work and good presentation. I thank you once again, both of you. And you have taken so much pain to share your expertise on this. Thank you, both of you.
Thank you, sir, for having us.
Okay, so I think we can start the questions now.
Yes, sir.
Yeah. Go ahead.
Can I share the question screen, sir?
Yeah. Yeah. So
This is the first question.
Yeah.
Can I start the question, sir? With your
Yes,
permission?
yes.
Please.
60 seconds
Sir,
time, sir.
answer we will give after each question or at the end?
Sir?
Once again?
No, the answers we will give after every question or at the end?
After.
At the end, sir.
At the end.
Every question 60 seconds time, sir. Now 20 seconds gone, sir. They started and they started responding.
What is the most common adverse effect of dupilumab apart from the injection site reaction? Your options are: number 1, glaucoma; number 2, non-infectious conjunctivitis; number 3, posterior subcapsular cataract; number 4, keratitis. So which is the most common adverse effect of dupilumab? So, Rajib, you're there?
Yes, boss, I'm here. And
Yes.
tell them that if they have listened to the lectures
Yes.
carefully, they know the answers already.
Yes.
Answers are given in the lectures themselves. They're very
That's
simple
fine.
questions.
So, shall we give the answer, sir?
Wait.
Okay.
They will say the time and then
Okay, sure.
Time up, sir. Next question, sir.
you can go to the next question.
Yes, sir.
Yeah.
The next question is, what combination of therapies has been reported to improve efficacy to treatment regimen? Number 1 is cyclosporin and NV-UBV. Number 2, azathioprine and methotrexate. Number 3, methotrexate and topical corticosteroids. Number 4, mycophenolate mofetil and topical corticosteroids. So what combination of therapies has been reported to improve efficacy? Slightly tricky, but I think Rajiv has brought this out in his lecture also. Am I wrong, Rajiv? Am I right?
Absolutely.
Time up, sir. Next question, sir.
Yes. Question 3. Which molecule is not a phosphodiesterase E4 or a PDE4 inhibitor? This I have spoken regarding the newer topical drugs that are available. Number 1 is crisaborole. Number 2 is roflumilast. Number 3, E605 or RVT501 molecule. Number 4 is ruxolitinib. So which molecule is not a PDE4 inhibitor?
Sir, time up, sir. Next question.
Yes. Question 4. Which of the ingredient in emollients have additional anti-inflammatory property? Number 1 is bisabolol. Number 2 is niacinamide. Number 3 is glyceretinic acid. And number 4 all of the above? Which of these molecules or which are used in emollients have additional anti-inflammatory property?
Sir, time up, sir.
Now we'll go through the questions once and go for the answers.
Okay, sir.
Rajib will answer the first two questions regarding this related to his topic.
Yes,
Rajib, the answer to question number 1. Rajib, you there?
Yes, I'm here.
So tell us
So
the answer to what is the most common adverse effect of dupilumab apart from injection site reaction out of this?
I have shown in my slide, it is non-infectious conjunctivitis.
So the answer is number 2, non-infectious
Infectious
conjunctivitis.
conjunctivitis. That was shown.
Yes. So number 2 is the correct answer for question
Exactly.
number 1.
Question number 2. Please go to question number 2. Again,
Yes, sir.
What combination? What combination of
combination
therapies?
of therapies has been reported to improve efficacy to treatment regimen. Again, I have also mentioned this clearly that mycophenolate mofetil reduces the necessity of using topical steroid. It acts as a very important steroid sparing agent. Cyclosporine NBUB cannot be used. Azathioprine methotrexate cannot be used because of both of them are heparotoxic. Cyclosporine cannot be used in NBUB as clearly mentioned. It not to be used with any form of phototherapy. Methotrexate topical corticosteroid can be used, but there is as of yet no specific data or reported data which suggests it helps in a steroid sparing capacity, which is there for mycophenolate mofetil. Boss,
So the
up
correct
to you.
answer is yes.
Is for
correct answer
mycophenolate
number 2 is
mofetil
4.
and topical corticosteroid.
Thank you, Rajib. Rajib has clearly explained why it's number 4. So the answer for question 2, the correct response is number 4. Next one. Well, which molecule is not a PDE4 inhibitor? The correct response is 4-ruxolitinib, which is a JAK inhibitor. The other 3 molecules are PDE4 inhibitors. So the answer to question number 3 is 4-ruxolitinib. This I had shown in the chart where I had shown the newer topical molecules. The answer is 4. Next one. Which of the ingredients have additional anti-inflammatory property? Bisabolol, niacinamide, glyceretinic acid, they are all having anti-inflammatory activity apart from emollient action. So the correct response is 4 or all of the above. So the correct response to question 4 is again number 4, where all of the above molecules have anti-inflammatory activity in addition. So I think we have come to the end of all the questions.
Yes, sir. So with your permission, shall I stop sharing?
Yeah,
Yeah, please. Over to Dr. Titan, sir.
yeah, it's very wonderful. I think we will wait for some time to
Yes.
hear the results. Bhavya, have you got the results tabulated?
Yes, sir.
Yeah, tell us. Question number 1.
Just a second, sir.
Yeah.
So question number 1 winner is Dr. Midun Manoj.
From where? From where?
Dr. Mithun Manoj, are you there? He's not mentioned, sir. Dr. Mithun Manoj.
Can you please share your university name and your phone number in the chat box, please? GMC Kannur.
Kannur, yeah. Congratulations. Next. Question number 2.
Question number 2 is iPhone, sir. Sir, iPhone, doctor, can you please share your details in the chat box? Doctor? Doctor, are you there? Yeah. Shakti. Dr. Shakti Jwala, can you please share your phone number and university in the chat box? Shri Mukambika Institute of Medical Sciences. Second question winner, Dr. Shakti Jwala.
Yeah. Congratulations. Where are you from? Please share the place.
Shri Mukambika Institute of Medical Sciences, sir.
Where is it?
Dr. Shakti Jwala, can you please share the place name too?
Mugambika is an Nagargoil.
Nagargoil. Okay. 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 Right. Third
question winner, Brisbane. Dr. Brisbane, can you please share your university and your phone number in the chat box, doctor? Dr. Brisbane. Tirunelveli Medical College, sir.
Yeah.
Third question winner, Dr. Brisbane, Tirunelveli Medical College.
Congratulations, Dr. Brisbane.
And fourth question winner, Dr. Ramisa. Dr. Ramisa, can you please share your university and phone number in the chat box, please? Medical College. Vizag, sir.
Vaishak. Yeah. Congratulations, Dr. Ramisa. So we have reached the end of this session. Next month, we will come out with some other interesting areas. So stay with us when we will announce the date in advance. It is somewhere in the middle of June, and the topic will be interesting, let us say. Thank you, Dr. Rajib and Raghubir.
Thank you, sir. Thank you very much, sir.
Yeah.
Thank you, sir, for having us there. It was an honor.
It was an honor for us, sir. Thank you very much. And thank you, East West Pharma, for hosting such a wonderful meeting.
So, thank you very much for, Ms. Bhavida and Naveen. Thank you very much.
Thank you, sir. Stay safe and stay well.
Yeah.
Thank you very much. Thank you, everybody.